I've given 3 lectures while I'm here. The first lecture was an overview on prognostic factors in relapsed and refractory Hodgkin lymphoma. In that session, we discussed the issues about the importance of pre-transplant PET imaging, and that those patients who are in remission at the time of transplant have a 3 out of 4 chance of being cured, versus those patients who are not have a 1 out of 3 chance of being cured. In the context of that conversation, we also discussed the issue of consolidation treatment after a stem cell transplant with brentuximab-vedotin. That was a paper that I published in The Lancet in 2015, showing a 20% improvement in progression-free survival in patients who did receive the study drug. The second lecture was more of a Meet the Professor session, where we discussed new agents in patients with Hodgkin lymphoma. In that context, I presented 5 cases to a group of folks who are interested in Hodgkin lymphoma, and we discussed how to manage patients with chronic disease. It's an interesting disease, chronic Hodgkin lymphoma. In 2007 or 2008, the median survival of a patient where a stem cell transplant failed was 30 months. The median survival in the same patient population now is probably closer to 70 to 90 months. So there's been a tripling in survival. And the reason for that is all the new drugs that are available that we and others have studied in this setting. The first being brentuximab-vedotin, which was studied from 2009 through 2011, which is an antibody drug conjugate to CD30. But the second was HDAC inhibitors. The parent compound was called panobinostat, which is not approved in Hodgkin lymphoma, but patients did have clinical benefit from that. The third was an mTOR inhibitor called everolimus, which has been championed by the Mayo Clinic group, which has good palliation. But most importantly, and what gets a lot of press right now, is the role of checkpoint blockade in patients with cancer du jour. But in fact, in Hodgkin lymphoma and its cousin, primary mediastinal large B-cell lymphoma, there's a genetic abnormality in the disease which causes upregulation of the receptor called PD-L1. So these diseases are primed to respond to a checkpoint inhibitor. And in fact, both nivolumab and pembrolizumab have tremendous activity in these 2 diseases and will likely get approved by the end of the year. Our T cells are in either a turned on or turned off state. They're turned on by binding to antigens through their MHC complex. However, our T cell response is muted by a variety of signals or enhanced by a variety of signals. Generally, the T cell response is muted by what we call checkpoint by a check. And these are usually, we call these inhibitory signals. So there now are antibodies which can block the inhibitory signals and turn on our T cells. These antibodies are either PD-1 antibodies, or they block the receptor, PD-L1, which is on tumor cells, allowing our T cells to turn on. So there is a laundry list of drugs out there right now that are exploiting this pathway. The 2 PD-1 inhibitors are called nivolumab and pembrolizumab. There are many PD-L1 inhibitors that are being studied. The ones that are furthest along, one is called atezolizumab, the second is called avelumab, and the third is called darolutamab. They're closest to being moving along in hematologic cancer. However, the drugs are, 3 of these drugs are already approved in solid tumor. In lung cancer and in melanoma and in bladder cancer. So these drugs are here to stay, and they're going to be used for excellent palliation. On the flip side, there are also drugs that stimulate the T cell. As opposed to blocking the inhibitory signal, there are drugs that just stimulate the T cell to turn on. These drugs are all in study right now. The one that's closest is a drug that an antibody to CD137 called urelumab, which is now being studied with, in combination with drugs such as rituximab and other agents to see if one can increase efficacy. So these drugs have revolutionized the way we treat cancer. Both nivolumab and pembrolizumab are going to get approved in Hodgkin lymphoma. I would predict by the end of the year. That lecture is going to be later today, which is a debate on early stage Hodgkin lymphoma about the utility of PET scans to risk stratify patients to requiring radiotherapy or not requiring radiotherapy. Although I am a medical oncologist, I've been assigned to argue pro-radiation therapy, so I'll discuss that later today. All patients with early stage Hodgkin lymphoma don't need to be irradiated, but in the converse, it shouldn't be that 0 patients are being radiated either, and we should be able to decide based upon pre-treatment risk factors or post-treatment chemotherapy response if patients should be radiated or not. I think it's helpful, yeah, I do. Forget about what the debate is. I think that PET-adapted research and PET-adapted management of patients with Hodgkin lymphoma is here to stay. There are a lot of new agents that are being studied. I mean, my last comment is the hot topic is, will we be able to use chemo-free therapy in patients with indolent types of lymphoma in the near future? That is something that patients want. It's something that is appealing to physicians, but it's not appealing to cost. And we'll have to see where that's going to go.